This is not a test. Stay calm in an orderly fashion. Make your way to the lifeboats.
Mayday, the ship is sinking.
All right. So welcome back, everybody, to our Lifeboat Addiction Recovery Cast. This is Friday Cast, which means that we are going to be interviewing today. Today, we're very, very fortunate. We have someone who is very large in specifically women's medicine, but she's doing a lot of really, really cool things. And I just wanted to get her on the podcast to be able to talk about some of the initiatives she started, some of the things that she's seeing in the community and all that kind of stuff. So, ladies and gentlemen, without further ado, please help me welcome Dr. Lori Burke. How are you today, Dr. Burke?
I'm great, Christian. How are you?
I am too blessed to be stressed. Thank you so much once again for doing this for us. I mean, we consider ourselves fortunate to have individuals of your caliber look at little old us and say, hey, I'll go ahead and do that.
Well, I appreciate the opportunity to speak with you and your audience today because I'm always excited to talk about some of the initiatives that we have going in the community and hope to grow.
Awesome. So I think, right off the get, just so people get to know you a little bit better, could you tell the listeners who you are, what you do, and kind of your personal experience in the field that you do?
So as Christian said, my name is Lori Burke. I am a board certified obstetrician gynecologist. I was born and raised in southeastern Michigan, did all of my training in the state of Michigan. Over time, I have grown my interests in addiction medicine and how that relates specifically to women's health. So I have been in clinical practice as an OBGYN this is my 10th year in practice, and over the last year put more of a focus on growing my knowledge and regarding addiction specifically.
Well, that's awesome. So I know I've at least gotten to know you over the last year through kind of that avenue of you branching out into addiction. What are you focused on primarily with addiction and women's health? How do those two things correlate with each other?
So certainly in my training and time as a physician after my training, I have found that addiction certainly doesn't discriminate and affects people from all walks of life. And I don't think any physician can say that it hasn't impacted their practice. So what I am motivated to do is try to make the coordination of care for women who live with addiction and substance use disorder, and also have other medical needs, specifically reproductive health needs, make that coordination of care as seamless as possible. As we know, everybody has difficulty sometimes getting to appointments and coordinating care with busy lives and the multiple demands. And the virtual world that we're existing in now has made it even more complex. So I just want to be an advocate for these women and help educate my colleagues in the healthcare profession and think creatively about how to make care more accessible.
So you touched on a lot of points there. So I'm wondering if you'd be willing to break it down for us. So first and foremost, as far as advocating for your colleagues, obviously you're a doctor, you're a high-level doctor, you've worked in ERs and all that kind of stuff. I'm wondering if you can speak, well, not necessarily ERs, but hospitals. I'm wondering if you can speak specifically to what you would like to tell your fellow colleagues, how you would like to advocate on behalf of these individuals, what you see maybe as trends that maybe need to be addressed.
Yeah, I mean, certainly some of the most impactful conversations I've had with patients throughout my career thus far, specifically patients who deal with addiction and substance use disorders, is their negative experiences in the healthcare setting. And that relates to stigma. So I think just generally educating ourselves as healthcare providers about the language we use when discussing substance use disorders and the concept of addiction, and educating ourselves about resources that are in the community. I mean, I don't think any single physician can handle all of the complexities of any one patient who lives with addiction and has other medical needs, but just being better equipped to reach out to community resources and know that everybody is willing to work together largely in the addiction field to help people be as healthy as they can be.
Good stuff. Good stuff. So I'm wondering if you maybe talk to the flip coin of that. So you talk specifically about your colleagues and what you would like them to maybe understand about some of the things that you're accomplishing or that you're seeing or trends that you're being able to identify specifically around women's health and SUD. What are some things that you feel maybe a pregnant woman or a woman with substance use disorder might be helpful for them to know as far as coming from, the medical perspective?
Yeah, absolutely. I think in general, what I've seen, certainly one of my roles as a clinician working in a hospital setting is I cover labor and delivery and triage and emergency room visits. And oftentimes I will see women who are struggling with substance use disorders present in crisis. And our team, as an OBGYN team, may be consulted to take care of an obstetric or gynecologic issue that the woman's having. And oftentimes, I think women who are in crisis related to their addiction are hesitant to seek care. And I really encourage women to take the steps, and I know it can be scary, and take the steps to protect themselves in all aspects of their healthcare, and that we are here to help them. And please be open and honest with us, because as they are more open and honest with us related to all aspects of their life and what's going on, we can more fully help them be successful in achieving their healthcare goals.
Wow. So I want to, once again, you brought up a really interesting point, and I know I see it a lot in the practice that I own and I'm a part of. How do you combat some of the fear of these women that are kind of coming in and saying, like, my doctor, I don't know what they're going to say, and are they going to take the baby, and how are they looking at my health? How do you combat that fear, and what do you have to say to women that may be pregnant and struggling with substance use disorder?
I think it takes time. You, just like any other relationship, when I approach any other patient to manage whatever their needs are, you have to build rapport with them and relationships. So you're not going to get to know everything and build trust with the patient one time. But I think as a healthcare provider, I try to just make a point to be very diligent and clear that I'm here to help them. I'm not here to judge. Please share with me anything you think that would be helpful, and really having close follow-up with them. That doesn't necessarily mean I need to see them in the office every third day, every 2 days, but we have been creative in abilities to connect with patients either through virtual formats like we are today, using the telephone, in-person visits, coordinating with peer recovery coach services, and social workers in both inpatient and outpatient setting. I think what I have seen is women feel more comfortable when they know the providers in different aspects of their health are coordinating. And in general, I'm diligent to tell patients my goal is to limit the number of surprises you experience and to try to let you know what to expect. Because I think any person appreciates that.
Absolutely. I think, open transparency and honesty is the best way to go, especially when it comes to medicine. I'm sure you know that better than most. Now, a woman comes into your practice, she doesn't have, she hasn't seen a doctor in, let's say, 5-10 years. What is kind of your first steps with her? How do you approach her in trying to begin to foster that relationship with her?
Yeah, I mean, certainly I just try to set a very comfortable environment and get to know them as much as they want to share with me at that initial meeting. And there may not even, if it's in an outpatient setting and there's nothing emergent going on, there may not even need to be a physical exam at that first visit. It's really just a get to know you visit. Tell me about what I can do to help you or what your goals are for the visit. And then we kind of dive into some general history questions. And then I make recommendations based on what they've shared with me, and we plan a follow-up.
Wow, that's what an amazing answer. So let's flip the script a little bit. I'm wondering if you can talk more specifically to maybe your practice or how you've approached things. So in your view and for our listeners, what is your practice? What do you do with a woman on an everyday basis?
Yeah, so I currently have a variety of positions that I'm serving in. I work in the field of medical education. So clinically, my position is as a residency faculty in a local OBGYN residency. And I help train physicians who are planning to specialize in obstetrics and gynecology in all aspects of general OBGYN. So prenatal care, general well women visits in an outpatient setting, emergency room care for gynecologic visits, labor and delivery, delivering babies, admitting women to the hospital who have problems while they're pregnant, and doing gynecologic surgery. And then more recently, I've taken a position as a medical director at a local medication assisted therapy clinic in the area. And it's largely taking care of patients who are using the medication of methadone to help with opioid use disorder.
So that's a very broad. So
Yeah.
you have the OB and then you have the medically assisted treatment. How do those two things, like, where do those end up in your career path? How do you go from one to like that?
Yeah, so ideally, what has been the most rewarding in the short time that I've been in both of these positions is that some of the patients I see at the medication assisted therapy are actually patients of the residency clinic for their obstetric and gynecologic care. And so I've been able to see how helpful it is when a provider is able to speak to both their addiction care and their OBGYN care and really assist in both realms to make care as convenient as possible for the patient, and I think ultimately improve outcomes for them.
Wow, that's awesome. So what would you say is a major motivation for you to start, I guess, branching off specifically into the substance use disorder field? What, you did quite a bit of work in women's health, but what made you say, like, this is a field that needs to start being addressed, and I think I'm the person to address it?
So really, my initial motivation occurred in my training when, as a resident, you kind of get in a routine of you admit patients to the hospital, you do their admission history and physical exam. And it was not infrequent that I would ask patients specifically about substance use disorder. And what's fascinating to me is pregnancy in and of itself is a huge motivator in general for women with substance use disorder to seek care or come to terms with that to finally address it. And many times I was shocked that maybe those specific questions were not asked, and or women would wait until right before they were delivering to let us know that that was happening. And so I thought, okay, well, I'm training in a bigger city. Maybe this is just a bigger city problem. And then my first job after my training was in a more rural setting, and it was happening there as well. And then I came to the Lansing area and it's here as well. So I said, well, this is obviously a huge problem. And I think I can improve my ability to be an OBGYN if I improve my knowledge about substance use disorder and offer management for addiction as well as OBGYN care. Because any woman who's been pregnant knows that no matter how uncomplicated or complicated the pregnancy is, the schedule of prenatal care in and of itself is brutal and has huge impacts on your life. There's a lot of visits, a lot of lab work, a lot of ultrasounds, but so is getting treatment for your addiction. And so anybody trying to manage a home life, maybe taking care of other children, trying to be compliant with their prenatal care and their addiction care, it can be a lot to manage. So trying to bring all of that together in a multidisciplinary approach to their care is what motivates me.
Mm. So why do you think that oversight happened? If you saw it in a large city, then you go to a rural setting, you're seeing it there, and then you're seeing it in Lansing. So it's clearly like, okay, there's an established pattern here. And from when you were talking about it, it kind of felt like you were the only one in the room. Like, is anybody else seeing this right now? Like, why is
Yeah.
this happening? It's not being addressed. Why do you think that is?
Well, I think in healthcare in general, there's a lot of pressure on providers to be efficient in the care that they provide. Reimbursement of many physicians is based on how many patients you see, and obviously, in any profession, you want to be efficient, and so everybody has a tendency to kind of want to stick in their own lane, and so have a very tunnel vision approach of, I'm just going to stick with what's my specialty and do what I can do because I'm only allotted 15 minutes in my schedule to see this patient, and I can't really go there because I think there's a fear that if I go there and I can't help them, I'm not really doing anything for the patient. What I have found is you can continue to be efficient if you are better equipped to help patients find the resources.
Very interesting. So it definitely sounds like, and I don't know if this has been your experience, but as you've started down this road, have you started to see maybe some of those doctors that, I don't know if siloed would be a great word, but that are just like, I'm going to stick in the discipline that I'm trained in. Have you seen them maybe start to put the feelers out, branch out a little bit and say like, well, this is interesting. What do you think? Basically, they were waiting for somebody to take the baton and start leading. And then they say, okay, maybe we can make this happen.
Yeah, I think certainly colleagues have certainly reached out to me either about specific patients or just kind of wanting to know a little bit more about what I'm doing and what my goals are. And I think if you're able to start a conversation, that's how you can really tear down barriers and build bridges for patients. And that's ultimately what I'm trying to do with my team.
Wow. So I think there's no better way to springboard into the next question, which is, what's your hope for all of this? What ultimately, like, you're here now and you're doing amazing things. I've been privy, I guess you could say, to some of the stuff in the background that you're doing, specifically with my agency and things like that. But what's your hope? What's the final end goal? What do you want to see happen?
So from a medical education standpoint, and I see it happening already, but starting in medical school and transitioning into residency, really make formalized education about the concepts of addiction, medication-assisted therapy, counseling services, peer recovery, really part of the curriculum in medical education for learners from all specialties. Because as I started in this interview, I said, patients with addiction see all types of medical problems, and so it impacts all specialties of care. So from the medical education side of things, formalizing that education for physicians in training so that when they come out, they are better equipped maybe than I was and generations before me to start asking those difficult questions and having just a background that they can serve patients that have substance use disorders. From a clinical practice standpoint, what I would like to see happen is that a woman can go to one place and access the multitude of services that are available, because I think there's a lot of people in the community doing a lot of great things for women. And there's a lot of people in the community doing a lot of great things for people with substance use disorder. And there's a lot of people in the community doing a lot of great things for people from a public health perspective. And if we can bring all of those services to one place for the time of pregnancy, because pregnancy is time sensitive, and trying to coordinate care in a timely approach to making sure everything is being monitored appropriately, you can't go back in time. That pregnancy is growing and progressing every day and every week. So kind of a single place where a woman can go during the time of their pregnancy and in that initial postpartum phase to see all of their providers or have access to them, is really my dream.
That's an amazing dream at that. That's awesome. So, you spoke quite a bit so far about your education, or how, being an educator, being a teacher. So, so you're getting students from the local universities who are coming in and they're learning from you. What are some of the things that you're teaching them specifically related to substance use disorder? And then kind of the second part of that question, which is, how are they receiving it? What are they wanting? Do they have a fervor for this? Or are they just like, oh my gosh, like, I don't know how to handle this?
Yeah, so I think that is where being trained in obstetrics and gynecology has been a benefit to kind of making addiction more of a focus in my practice, is that OBGYNs are known for having to ask very personal, very awkward, sometimes difficult questions to women, either about their sexual health and history, or social status and history related to trauma and abuse and safety. And being a practitioner now in addiction, you have to also be comfortable. You have to go there, is what I always tell the learners. You have to go there. You have to ask those hard questions. And oftentimes, learners early on are kind of stumble in how to frame those questions. And I try to encourage them that it's normal to be uncomfortable asking this, because I don't think the lay population has these types of conversations when you have a 15-minute encounter with the patient, or somebody presents in crisis and they're having a true emergency, and you really need to ask them, hey, I'm seeing some things in your vital signs. Is there any chance that you use heroin? That can be a little awkward to do, but just help coaching them through that and giving them some examples of how I phrase things and watching them grow is so exciting for me as they become more comfortable asking those questions.
Yeah. So is there anything that you relate to your students of maybe literature that they should start reading into, or TED Talks that they should start watching in relation to this type of stuff?
Really, in general, I think I try to make them aware that as students, what's great is you can really become members of many of the professional societies, like ASAM for addiction, or ACOG, ACOG for obstetrics and gynecology, and they offer free memberships for students. And any specialty of medicine loves when students are interested in their particular specialty and welcome them. So just, having them get involved and early on in their careers, bringing them on with various projects that may be happening. Or what I tell students is, if you find something that, as corny as it sounds, if you find something that makes you passionate, that will help get you out of bed when your alarm goes off at 4:45 in the morning and you have a 12-hour shift at the hospital ahead of you. But it energizes you and motivates you and helps you have a long career.
Yeah. So I know from personal experience and statistics that are happening nationally that the amount of women that are being born with or that are having children that are have THC in their bloodstream is astronomically high. Can you maybe talk a little bit to why that trend is happening, what the hospitals are seeing about, or to do about that, what maybe you as an OBGYN is kind of trying to do to combat that, or how you kind of unpack that for your students?
Yeah, I mean, really with marijuana use, I think the entire medical field is kind of grappling with the concept in the state of Michigan with its recreational legalization is what does that mean now when marijuana shows up if a patient has a drug screen? I think it is important to just very directly ask a patient about it, is what I encourage other providers to do. And I think there is a ton of research related to pediatrics and women's health related to how does marijuana use affect a pregnancy, either during the pregnancy and the development of the child long term. The greatest concern is, as you know, Christian, substance use of one type often leads to or is affiliated with substance use of other types. And so that truly is the focus. We know tobacco is not recommended in pregnancy, and we know that alcohol is not recommended in pregnancies, and these are substances that are legal to use. So just because it's legal doesn't mean it's healthy during your pregnancy. So ideally, we recommend cessation of all substance use in pregnancy, recognizing that they are often addictions, and patients don't often view use of a legal substance as an addiction. So having to work through those conversations and mechanisms to cut down can be a challenge and often time consuming, but ultimately then if we can achieve cessation of any substance use in pregnancy, we encourage patients, well, you've quit during the pregnancy, so why don't you just continue? And oftentimes they do, and it's exciting to see.
That's awesome. So maybe you'd be willing to talk a little bit along that line of thinking about the importance of a collaborative care team, the importance of not only having the OBGYN, but having maybe a different doctor involved, or having a therapist or things like that involved. How do you see those things interplaying with somebody that is pregnant and is addicted to cannabis or some other substance?
Yeah, I mean, certainly I think patients, I often in my work at the hospital will see patients truly in crisis. Either they're having, there's a phenomenon called cannabis hyperemesis syndrome, where actually the use of cannabis can induce severe cyclical nausea and vomiting. Often patients report that their only relief they get is if they sit in the shower or in the bathtub. And that can be complicated because pregnancy in and of itself can cause a hyperemesis syndrome where women have severe pregnancies. So I think the biggest thing is kind of leaning on colleagues that have knowledge that you don't. I mean, the greatest thing I've learned as a physician is that the physician doesn't always know everything in the room. And that can sometimes be a hard lesson to learn, but I've learned from working with your team, Christian, that peer recovery coaches are a huge resource for our patients, because patients often just don't know where to go, or where are doctors that aren't, where are doctors that will accept me and address my addiction and can show me where I can get care for this, that, or the other thing, insert whatever diagnosis you can think of: hypertension, hepatitis, diabetes, pregnancy, you name it. Patients with addiction is just one aspect of who they are. It's not their entire self.
Yeah, so on that kind of line of thinking, I'm wondering if you'd be willing to talk to, one of the biggest problems, at least I know from my side of the field, is the stigmatization of whether it be in the medical field or in the legal arena or whatever it might be. So how do you teach your students? How do you perceive destigmatization in women specifically that are struggling with SUD as important to their healthcare? So, or, not fostering a non-judgmental atmosphere, I guess would say.
Yeah, I think, listening to you ask me that question made me go back to when you mentioned the word transparency. I think I always encourage patients, like, I would rather hear from you what's going on with your substance use than a laboratory result and then ask you about it. And that has been a useful concept for me in my caring of patients. In addition, patients often, like I said, no patients like surprises if it can be avoided. So if you know things that can be expected for patients in their course of care, it's helpful to have those conversations with patients. If it's a patient who's actively using illicit substances and is pregnant, I will tell them, this is obviously going to be in your medical chart, and when the child is delivered, often that will result in social work being consulted to be involved in your care, and child protective services, because at the end of the day, although child protective services is often has a negative connotation, the goal is to just make sure that that child is going home to a safe and healthy environment.
Yeah.
And patients often appreciate that, as uncomfortable as it can be to have those discussions. I have found that patients appreciate knowing that, that could happen versus it just being quote unquote sprung on them when they show up and are recovering from a delivery.
Yeah, and I mean, I know obviously it's not to that level of intensity. They just had a baby and then all of a sudden CPS is coming in. But I know in my personal experience, the level of transparency is directly equal to the success of the outcome that you're going to have. Because if they know what's coming, then it happens. They're not going to, they won't hold anybody responsible other than themselves, and they'll understand what's happening. So I'm wondering if you can talk to maybe your biggest hope for things that you don't want to see change in women's health, maybe things that you're just like, this is really good how we're doing this right now. I do not want to change this. Yes, there's other things that we can change, but right now this is where we need to be at.
Yeah, I mean, one of the things that drew me to the field of obstetrics and gynecology, and this is, I don't want to pigeonhole or put labels on specialties. OBGYNs in general are huge advocates for their patients. And even at more public health level, the specialty at large, I mean, we have subcommittees and groups that, participate in lobbying at the Capitol building or at national levels to improve access to care for women. So I am so proud to be part of a specialty where that is what we do, and increasing access to services like contraceptive care and prolonging how long women are covered for postpartum care are all great things that I am so excited that we do as women's healthcare providers, and I'm happy to be a part of it.
Awesome. So now, kind of the flip coin now, other than obviously funding and the level of intervention and all those kinds of things, what are your biggest fears for women's health, for maybe the substance use disorder as it relates to women's health? What are your biggest fears that maybe you see happening inside of the field right now that you're like, that we may need to handle that, or that might become a problem later on?
Yeah, I think sometimes at a professional level, it is complex and complicated to provide all-encompassing care at the addiction level and the women's health care level related to things like how providers bill those services and things like that. Because, I mean, obviously, any healthcare provider wants to be compensated for the work that they do. Certainly, I don't think nobody does this. You can't do this work for the money, but it's about, being able to be appropriately reimbursed for your time, and coordinating care, as you know, Christian, is a very time-consuming practice. And I love what I do for a short amount of time as I've been doing it, but I feel like this is truly my passion project, if you will, and it makes me excited to serve women with these needs. But common questions I get is like, well, how do you bill for that, and what do you do? And thankfully, some of the projects I've been doing are more grant funded projects and reaching out at community levels to patients. So I haven't yet seen that side of things, but it makes sense to me that providers have those concerns. My other fear is over specialization just in the field of medicine in general. Now, don't get me wrong, I feel like specialty care is definitely needed, and it's a great thing about medicine, but the concept of that's not my problem to deal with is dangerous, because I think that you run the risk of not providing the best care to a patient if you don't take into account everything that's going on with the patient, not just from their physical health, but social health and mental health. And if they happen to be struggling with addiction as well, incorporating that into your lines of questioning, because if you are recommending therapies that are not realistic or that a patient just can't get to because they don't have the transportation, then that's great that you can make that recommendation, but we really have to work together as a team with our social workers, our peer recovery coaches, our addiction specialists, and medical specialists in various fields, so that we can come to treatment plans that make sense and are doable for patients. Because in general, patients don't want to be non-compliant, but they just realistically don't have the tools to execute the various care plans that individual providers have for them.
Yeah, wow, there's a lot there. So I'm wondering if you can talk maybe to the student who's listening to this, or the provider who's listening to this, because we have gotten feedback from providers. They're listening to this podcast, and one thing that they want to hear is, what is one caution that you would give to a student within their first couple of weeks or whatever it might be? And then what's one piece of wisdom that you think every student, provider, whoever it might be, should know before getting into this field, or should know while they're in this field?
That's a great question. It will affect you emotionally. I think you have to be able to take care of your own mental health and have things in place and colleagues that you can decompress with and get support from, and a supportive home life, because there are tragedies. We can't save everybody, and there are outcomes that are not great, but take care of yourself fully, and that's mentally, emotionally, have ways to decompress, because it is stressful. And if you keep yourself healthy, mind, body, and spirit, then you can do the best for your patients.
Wow. So we only got a couple of minutes left. There's just some, rapid fire questions that I'm wondering if you'd be willing to answer. What are some things that you had to unlearn since you've started your career and since you've progressed on in your career?
The concept of being done. So when you're trying to go to medical school, you're like, well, I'm just going to take this test and then I'm done and I'm good. And then I'm going to finish residency and I'm good. And I'm going to get board certified and I'm good. I've just let go of that, because I always find something I want to learn more about. And now I am seeking board certification in addiction medicine and enrolled in the MyCares program, which is a collaborative with Michigan State University, Wayne State, and Spectrum Health for providers who are practicing. So attending providers who are practicing and are interested in incorporating addiction medicine, they can sit for their addiction medicine boards after kind of achieving a certain level of hours in the field of addiction. So that is my newest thing I'm trying to do. And the concept of being done. You're never done. There's always something, there's always more to do and more to learn.
Well, and I love that concept of, it's a progression. As long as you're alive, there's always something that you're going to learn. It's never done. So what would you have to say to a student that, they've studied for that midterm, they've studied for that, final, they've studied for whatever it might be? What would you have to say to them to say, like, hey, there's a difference between the test and then actually walking this out? Like, don't become so focused on, the intellectual part of it that you forget the emotional part. How do you cross that barrier with students?
I think life balance is a huge thing. It's a hot topic in medical literature right now about physician burnout and wellness, and what wellness is to everybody is different. And what wellness is to physicians in training and physicians who have been doing this longer time, I think, is an interesting concept. But what I tell my learners is that, yes, you have to pass the tests and you have to achieve your board certifications and check those boxes, so to speak, but never think you know everything,
Mm.
that you can learn something from everybody. And, you know, for me, the journey has been not only now going into this field of addiction and helping women with substance use disorder, but also taking a more concerted effort to achieve balance in my life so I can put energy into this mountain of a goal I've set ahead of myself.
All right. So my final question to you, and I think I'd be remiss without, without addressing the elephant in the room, if you will, COVID-19. How are you navigating with your students in the midst of COVID-19? How are you navigating with the participants in your program, your clients, whoever they might be? How has this process been for you as a doctor?
I didn't realize there were so many platforms to do video conferencing and creative ways to communicate just with colleagues, patients, everybody.
Everybody wants you to download some kind of hardware or software, don't they?
Yes, exactly. Just when I think I've figured them all out. But I think everybody is exhausted by the whole concept, but I think in general, there's a huge motivation around the availability of vaccines becoming greater for patients who choose to get them. And we just, as our staff in our offices, it's just now more the norm. Like, well, the patient says she can't come. Is there an ability that we can connect with them in a virtual platform? And that has now integrated in many of the electronic health records that I use in the various roles that I serve. And I think once we are past this pandemic, which who knows when that's going to be, but when we are, I think telehealth and virtual connection with healthcare providers and patients will be here to stay. I really think that is a great service to offer.
Well, Dr. Burke, thank you so much for your time. Is there anything that you want to say to the audience, maybe to come and find you, any blogs or anything that you have going on like that?
I just am so happy that programs like yours exist, and I very much appreciate you, Christian, for having me here to speak today. And I would be happy to help any patients that feel like I could be of help to them for reproductive health needs, obstetric care, gynecologic care, or if they are seeking medication-assisted services. You can connect them with me, Christian. I'd be happy to chat with them.
Absolutely. And those who are listening, you can connect with Lifeboat. And if you are somebody that is looking for that type of care, we can, of course, connect you with the great Dr. Lori Burke. Thank you so much for being on the podcast today. You have yourself a great day.
You too, Christian. Thank you.